Thank you very much. Thank you for the invitation. It's an honor to be here. I think the opportunity to speak about this tonight is very timely because we're expecting the federal panel that's producing the guidelines for MAiD for mental illness to release its report tomorrow if it's released according to the planned date. So very timely that we're talking about this. My experience over the past year since the legislation, Bill C7, was passed, is that a lot of people in Canada have no idea that this has kind of happened. I have conversations with colleagues over and over that they're surprised by how wide the door has been opened with respect to MAiD, and that MAiD is coming a year from now, March 2023, for mental illness. So with that, let's talk about some stuff. Alexander Simpson, Sandy Simpson, he's the head of forensics at CAMH, and he asked, when is it ethical for one person to ask another person to kill him or her, or to be party to that person's death? What ethical burden does it place on that other person? It is not the right to take one's life that is being sought. It is the right to involve others in one's suicide. We have literally a couple of thousands of years of reflection, philosophical thought, theological thought on suicide. And suicide is a deeply entrenched taboo, has been in our society, but something is fundamentally shifting and shifting within this debate. And we should be concerned about it. So what do you believe as a person? If you believe suicide is an autonomous individual choice and that suicide prevention is an indefensible intrusion into someone's life, then no further discussion is possible. That's the position of extreme autonomy. Excuse me, it's a movement away from the common good to the belief that each of us can do what we want. And that belief is certainly been made manifest by a 250,000 member organization in Belgium right now that is advocating for an over-the-counter suicide pill. So suicide on demand. And those people who say that there's no slippery slope, all we have to do is look at the 3 countries in Europe that have been doing this for about coming up on 20 years now to see where this stuff is going. There was a bill introduced in one of the parliaments there suggesting that anyone over 75 should have access to a suicide pill simply by virtue of age, not because of suffering, for no other reason, not because of illness. If you believe that suicide prevention is an important ethical and social good, then I believe you should be concerned about MAiD for mental illness, because we are talking about suicide. Those who say that this isn't about suicide, that MAiD is something different, I want to challenge that claim tonight, because it's, I don't believe, a defensible claim. What has Canada done that's different in the world? Are we all aware of this? We've had the fastest introduction and adoption of MAiD practices in the world, right, over a 7-year period. And what is our current claim to fame? On Vancouver Island, we now have the highest rate of MAiD euthanasia in the world. And that's against a backdrop of legislation in Switzerland from 1937 that allows you to take a pill to kill yourself. It's against a backdrop of decades of this being legal in 3 European countries. So why so fast? Well, Vancouver Island, there's an aging population. We have physician activists. There's also a strong cultural push to normalize dying this way. But why is it in Europe? They've leveled out at about 4%. We've been going up 1% a year with no clear end in sight. Where's that going to level off, and what does that say about Canada? Well, one of the key differences is in other countries, the very few countries that allow this practice, you're expected to try treatments first. In Canada, we're not. So we're the only country in the world that has legislation that says you don't have to try standard treatments first. The next point there, palliative care, disability supports, mental health services are optional in Canada. Optional and not widely available. Palliative care, only 15% of the Canadian population has access to team-based palliative care, only 30% to skilled palliative care. So when you see stats saying that people who have had MAiD for terminal illness had access to palliative care, that it was 80% of people, they're talking about going to their family doctor for pain control. They're not talking about subspecialty expertise. I worked in palliative care. I worked in pediatric oncology. When you have good palliative care, pain is not an issue. You don't have to worry about dying, suffering from physical pain is the reality. But we have no legislative legal requirement to provide palliative care. Same is true of disability supports. People are choosing MAiD because they don't have enough financial support to keep living. Mental health services, I'm going to come back to that because it is appalling, the stigmatization that is at work in the mental health services field. But MAiD was made mandatory under federal legislation. Every Canadian is legally able to access it while they cannot access those other services. An interesting point, I think, is that the mental illness clause, the sunset clause as it was called, when it was added to the legislation a year ago, it was 1 month from it being added in the Senate until it was passed in the House of Commons. And it was passed in the House of Commons using a closure motion that allowed 3 hours of debate. So on a fundamental social shift where we're going to help people with mental illness kill themselves, there was 3 hours of discussion, which I think is quite remarkable. And what was further remarkable, a number of MPs after that vote, in answering questions from their constituents about how this happened, hadn't even realized what they had voted on. They didn't know that this clause had been put in. So what's next? Offering death while people are on wait lists for mental health services. That is where we're going. Absolutely, that is where we're going. There's no other way the guidelines coming out tomorrow will do other than that because of the lack of services and wait lists of up to years. I want to offer a counterbalance to the glorification of MAiD in terminal illness contexts. Beautiful deaths, family around, everybody happy, avoidance of suffering. What we're talking about here tonight is for mental illness, a whole different context where people have decades of life left. But MAiD is a message of deficit. You will lose control. We know that the majority of people who choose MAiD for terminal illness in Canada do so because of a fear of loss of control. You will lose dignity. The meaning of dignity has been perverted in this discussion. Dignity is how I view myself as a person. If others judge me or treat me badly, I have not lost dignity. They have lost dignity in their judgment of me. But the message here is that, if you're frail or, people have to do things for you or bathe you, that you have lost dignity. This is a misunderstanding of what true inherent dignity is for each person. And I worked in palliative care for a number of years. When you watch a family, when you see what happens in a palliative period as families move towards death, I believe that there's something being lost that's profoundly important here. And we can call it unfinished business. We can call it people, getting ready for death, having a good death. We can call it a lot of things. But what it fundamentally is I think one of the richest human experiences possible. But we're raising a generation through modeling with MAiD to believe that suffering is meaningless. I'm not arguing for suffering. I'm here talking about how we can relieve suffering in mental illness. But we're raising a generation with a very significant value shift, not just around suffering, but suicide. Excuse me. So if I want to die because I'm alone or I don't want to be a burden on my family, people have misunderstood again what burden is, because burden means being loved, and love means that the burden is welcome, and love means that it's not burden in a negative sense. So where are we at? The legalization of assisted suicide sends a message that suicide is a socially acceptable response to aging, terminal illness, disabilities, and depression, and subsequently imposes a duty to die. There were a number of very prescient articles written after the Rodriguez case in 1995 about how where this was going was that governments will want to shape our views about our duty to die because it's cheaper. So today we're talking about people whose primary underlying condition is a mental illness who want help completing suicide. I want to talk right at the beginning about the role of hope in all this. The therapeutic significance of hope must be acknowledged. When someone comes to see me, they're coming because they're hoping for relief of their suffering. When mental health care opens the door to admitting hopelessness, there is a danger of a self-fulfilling prophecy. Proponents of assisted dying in mental health care overlook the dangers posed to mental health services by the institutionalization of assisted dying. I'm going to talk to you in a moment about what's happening in my practice, in the real world, as a result of the background context where people now know that they can die by MAiD who have mental illness. The impact is profound. Excuse me. It's the problem of destroying hope. The social and legislative approbation, the approval of MAiD for mental illness, affects the clinical relationship. When you have severe and persistent mental illness, recovery is slow. People don't see the recovery points. As the last line says, their recovery lies just beyond their emotional and cognitive horizon to recognize. They're counting on their psychiatrist, their mental health clinicians, their care team, their mental health caregivers to show them a way that they can't find themselves by virtue of illness, by virtue of circumstance, or by virtue of, in Canada, the stigmatization. We push people to poverty. We offer people $1,200 in Ontario to live when rent is $1,200. There's no money for food. All of my clients, all of my patients rely on food banks. We push people to the margins and wonder why they lose hope. 4,000 Canadians are going to die this year by suicide, a tragic figure. Of the 100% of people who attempt suicide, only 23% try again, and only 7% actually complete suicide. What is that number going to be with the introduction of MAiD for mental illness? We know in the 3 European countries, this is very recent data, just published 2 months ago, people hadn't done the work to sort it out. We know that the suicide rates went up in parallel with the introduction of euthanasia there. They went up. People thought it would go down because they thought, well, these folks are going to get MAiD instead. But they went up substantially, 10, 20, 30%, women in particular. So there's a suicide contagion phenomenon that is real. And that hasn't been acknowledged in Canada yet because the data wasn't there. And when the courts were looking at this, the very few cases, the judges said, okay, doesn't seem to be having an impact on suicide. And they assumed that to be true without the data. 75% thoughtfully plan their suicides. I put that in there because you've made advocates who say repeatedly that this is different than suicide. Suicide is some sort of sudden, impulsive, horrible, I'm going to jump off a bridge kind of thing. It's not the reality. It's not the tragic reality, okay? So we're talking here about converting suicide from a freedom to a right. I am, to be crass, to be blunt, I am already free to kill myself. I can go online and find manuals that tell me how to do it in under 5 seconds. Making something a right means somebody has to satisfy your earned right or the right that's owed you. And in Canada, what they did was they put it in the House of Medicine. Who am I? Why am I here talking to you? I was trained initially as a medical ethicist, then became a psychiatrist. I work on an assertive community treatment team. There are 80 of these in Ontario. There should be 130, which should tell you something. That means there are 5,700 people in Ontario as we speak, waiting for tertiary psychiatric care, subspecialty care. I only treat, for the last 19 years, the people with most severe and persistent mental illness, the people who will be most affected by this legislation because they've been sick a long time and have severe illness. And yet, we have up to a 5-year wait in Ontario, long waits across the country, lack of services. Why is that? Is there any other area of medicine where you would let people with degenerative brain diseases go untreated? If I had a brain tumor and I see my family doctor, I'm in Princess Margaret tomorrow for specialized care. If I have schizophrenia, I'm 18 years old, I've got a neurodegenerative disease that if I don't interrupt the disease process, guaranteed I'm going to get very, very sick for the rest of my life with a 10% suicide rate because it's a horrible disease. And yet we don't offer treatment. Only 1 in 3 adults in Ontario have access to mental health care, only 1 in 5 children. We should be ashamed of this as the wealthy country we are. What's going on in my life now? I have a patient who says to me repeatedly, if a doctor kills me, it's not suicide. And I say, what is it then? Well, it's something different, because if a doctor says it's okay, it's okay. Somehow the white coat affords moral exoneration. It's permission. It's not suicide. And this is a person who would never kill himself with suicide, but if a doctor does it, it's okay. And you may not appreciate this question, but I've talked with the person trying to understand what's going on. And I said, if you're getting someone else to kill you, isn't that like getting a hitman to kill you? And again, no, it's not that. It's a doctor. And it wasn't about the means. It wasn't about sure death. So I don't botch it, as the expression goes. It wasn't about being there to comfort me. It was that a doctor makes it okay. And I think we need to think through what that actually means as a medical profession. I had a patient who started with me, and her parents asked, will you treat our son? His parents asked, will you treat our son or kill him? I've never been asked that before in my entire career. And because they were following what was going on with MAiD, and their son wants MAiD, even though their son is responding very well to treatment. And I'll stress that the people we see, on average, it's about 3 years to stabilize and treat things. And then thereafter, you're helping people move back into a full life to thrive. These are not short-term undertakings for the sickest people. I have a patient right now, she's refusing her psych meds to make herself eligible for MAiD. The treatment has worked, the disease has worked, she's had enough. It isn't about the disease, it's about stigmatization, it's about loneliness, it's about not having friends, it's about living in poverty, it's about living in a grotesque rooming house. And I'm not overstating this, rats and bed bugs. This is our daily work. The teams I work on, they're 12-person teams. We work in the community. This is asking for death for reasons that are easily solved. The college in Ontario is requiring of us that we make an effective referral to someone who will provide MAiD if I am unwilling to. I'm not sure how you do that in good conscience when you believe the illness is treatable and that the reasons, the opportunity, the lack of services are unavailable to this person. I added these 2 last things just in the last 2 days because I get calls from people seeking advice now. It's part of our world. It's already there. I got a call from a colleague. She has a patient with a conversion disorder. So physical symptoms, 97% treatable, young guy, 22, wants MAiD because now he knows it's allowed, doesn't want to have to go through treatment. It's embarrassing that he's got a mental illness. He'd rather be dead. There's a developmental reality to that. He's young, can't stand that this is how he would be seen or others would see him. And when my colleague said that it's not yet available, it'll be another year, he contacted Switzerland, where he did it because the websites were warm and welcoming. The MAiD teams, the clubs that are there that he spoke with such utter confidence. And I've heard this from patients in Canada as well, looking at MAiD for terminal illness. The confident offer of relief against a backdrop of having to do some work of healing, especially if hope is threatened and you don't believe healing is possible. And any of you who have suffered from mental illness, suffered from chronic pain, suffered from prolonged illness of any sort, you know how critical hope is. You know what it means to imagine and believe that there is an endpoint. And the last point there, that a gentleman who's in a nursing home, his psychiatric illness is completely well controlled. He's in a wheelchair. He grew up on a farm, lived on a farm, completely cognitively intact. He wants MAiD for boredom. No other reason. That is absolutely the only reason. And he's going to get it because he can't walk. He has a physical issue, not degenerative, just a physical issue, which will be sufficient. Disability is sufficient. So he's going to die. So I'm now being told by MAiD advocates that I should be able to predict what I can't. I should be able to say who's going to get better and who's not. The work I do, I have the benefit of hindsight. People come to me after years of being tried on other treatments, which helps guide my treatment. But what I also see is people who have never had proper subspecialty care because of the lack of services. How am I supposed to say who is not going to get better when my clinical experience is I've seen people get better after 5 years, after 10 years, after 20 years? And I've never seen anyone where we couldn't reduce suffering, never, because suffering is not solely a disease, ever. It's how we understand the disease. It's being made to feel like you matter. It's being part of a community of support. It's feeling that people care for you. So a real question tonight, with the guidelines coming out tomorrow, if I can't predict who's going to get better or not, and I say that I think they're not going to get better, it's a best guess based on failing treatments previously, how many times is it okay to be wrong? Because it is guesswork. And I'm telling you, as a subspecialist who's doing this, it'll be 20 years next year, all I do is treatment-resistant disease. I can't tell you which particular person is going to get a lot better, a bit better, or not, right? And yet we have MAiD advocates saying we should be able to just do this. There's no science, there's no evidence, and there's actually no clinical support for the claim, but we're doing it anyway. So what can we do in Canada? I can take the pill myself, which very few people do. I think it's 98% want the injection, the needle. I'm not sure why that is. There's a psychological piece to that. There's also, it makes it more medical. There's the drama or the creation of a, the doctor doing the visit, being there at bedside, needing to do something medical. I don't think it's complicated to give someone a pill. I also don't think it's complicated to put an IV in. Do I get a doctor to inject me? What do we have in the world? In Switzerland, 1937, the law said you could take the pill yourself under certain conditions. And the conditions really amount to I've got a disease I'm not getting better from. So doctors aren't involved other than to say, here's the illness. The person decides if they want to die and they get the pill prescribed. And they take it in a suicide center or at home with the support of, they've set up clubs in Switzerland. You've probably heard of Dignitas. So interesting model, been around a long time. And I'm sure somebody will correct me if I've got this wrong. I think only about 800 people last year or so made use of that, compared to the thousands and thousands we already have in Canada. So in Canada, we've got both options. In the United States, they only allow the swallowing of the pill prescribed by the doctor. I'm not sure how many states we're up to now, 9 or 10. So medical assistance in dying, I get annoyed by the euphemism, how this has been broadly applied. I don't think it's a medical act. I've argued this with people because it doesn't take medical skill to give someone a pill. And as we're seeing in Belgium, we have death centers where people come in. We also now have vans with death technicians prescribing what the people need. Assistance, again, at the risk of being crass, why do I need a legal service, a legal right to do something I can already do myself? And obviously I'm trying to prevent suicide. So I don't want anything that makes it easier. Suicide prevention is about offering hope. It's also about putting speed bumps in place to try and get people help, to sort out what is the distress, what is the suffering that you're enduring that makes death in your mind better than life, because we can do something about it, but we have to choose to do something about it. So MAiD in this context is a euphemism for suicide facilitation. Canadian case law in Rodriguez, the Supreme Court said no, the protection of life is critical here. In Carter, that decision was reversed in 2015. And let's be clear, the decision was about a woman with ALS who wanted to know that she could live longer, a while longer, and get to the point where when she was ready to die, she could get help to do it, because otherwise she was going to have to kill herself sooner. So the court made an exemption to the homicide law, saying, okay, we don't want you to have to die sooner, so we'll help you a little later. The key principle in that decision was we're trying to preserve as much life as possible. That was what the court was saying. And they explicitly excluded mental illness. So I'm frankly growing tired of MAiD advocates saying that the court, didn't close the door on it. Well, they explicitly excluded it. Read the decision. Fast forward to 2019, and intrusion, a lower court in Quebec, one judge said, I'm going to open the door wide open. People with disabilities. I'm going to eliminate the requirement that death be reasonably foreseeable that had been established in Bill C-14. And I stress Bill C-14 in 2016 went well beyond Carter. So what we have right now is we have a lower court case that the federal government chose not to appeal to the Supreme Court. So the reasoning has never been validated. And I would argue strongly that the reasoning would not be validated, because what we have as a Supreme Court stated principle to date is preservation of life. And what we've got is a consequence where life is going to be foreshortened for tens of thousands, if not ultimately hundreds of thousands of people over time, not what they intended. And what's remarkable about Canada, as I said earlier, the court sets a subjective standard of suffering, meaning if you say you've had enough, that's good enough. You don't need a doctor. You don't need some comparison with all other people with your types of illness and stage of illness. You're free to refuse all treatments in Canada, a sacrosanct principle. So what have we got? March 17th, 2021, we have two tracks now, one, death being reasonably foreseeable. And I'll just say under the previous legislation, that was stretched out to 10 years. And the people who were getting it, if you were diagnosed with a degenerative disease, that you'd go downhill for 10 years, that was allowed. So if we think that the existing law, the previous law and this law meant near death, that was not how it was applied. In other jurisdictions, they have defined what they mean by terminal, typically 60, 90 days before anticipated death. And track two, the second way you can get MAiD now, continuing decline, subjective suffering, irremediable. Dr. Tang is going to talk about this, I think, at some length, but disease may not go away in mental illness, but we sure can comfort, and we sure can stop the progression of diseases. Disability, any physical illness, mental illness, a year from now, it'll be there. What does that mean? Think about the numbers here. So we went from the court saying this is a very rare circumstance, a very rare case where people can't kill themselves on their own because the disease has progressed, so let's help them, to this. 50% of all Canadians have or have had a mental illness by the age of 40, 19 million people. 44% of Canadians over the age 20 have a chronic illness. Some of those are severe. Some of those are not particularly going to affect your life in a big way and maybe quite treatable, but they will be sufficient as a justification should you choose MAiD. 7 million Canadians have disabilities. We know the disability community has been decrying this legislation as discriminatory, and they were ignored. So 27 of 37 million non-terminally ill people in Canada could qualify. Those numbers I find remarkable. A law that under the weight of its own legal precedent cannot set any sustainable limit on accessibility to what is supposed to be a rare outcome of last resort is both naive and dangerous. This door has been flung wide open. It rests on a fundamental, and I would argue, misleading statement of priority. MAiD advocates focus on equity, equal access that ignores differences. Their argument, we respect your autonomy, your right to stop your suffering and die with dignity. What's equity versus equality? Equity would be like saying every kid in the schoolyard should be allowed to play in the sandbox. Equality is every kid should be allowed to play in the sandbox, but we're going to take into account the kids who are in wheelchairs, the kids who are disabled, the kids who have other needs. So the equity argument is simplistic, but an easy sell. This is justice. This is fair. This is playground simplicity. The reality of life clinicians, disability organizations, the United Nations disability rapporteurs, indigenous groups, mental health associations, on and on. We're all focused on equality. We want to restore your autonomy by treating your suffering. Very different goals. The first is an easy sell. The second requires understanding of what we're actually talking about is at stake here as human beings who care for each other. I'm going to add that this is critical that professional bodies weigh in. They carry weight. They have carried weight in this debate and the passing of legislation. They've also been misused, and some associations, or one association in particular, has misused its authority by not representing its membership's views. So there's no such thing as neutrality. Being quiet on this, there's a whole academic literature on this. If you don't weigh in, you're letting it happen. Okay, it means removing barriers. The World Medical Association, it's unethical. It's wrong, period. Canadian Mental Health Association, it's wrong. It's wrong because there's their line. We do not believe mental illnesses are irremediable. Okay? There's no science to support this. The Center for Addiction and Mental Health, a premier research institution in the world. A lack of evidence that mental illness is an irremediable medical condition in individual cases. So if anybody says there's consensus on this, as some are, it is, and that it's a fait accompli, that everybody's on board with this, it's a complete falsehood, to be frank. My own association, we care only for the sickest. This statement goes back to 2018. Same thing. We don't believe the conditions are irremediable or you can't identify who it is. The American Psychiatric Association, biggest association in the world, says you don't do it. You don't cause death. Canadian Psychiatric Association, this is the organization that didn't represent its larger membership's views appropriately, and I think has a lot to answer for in terms of what it did with having an effect on this legislation. And Dr. Tang will be talking about that. Psychiatrists are split. We only have small samplings to date. 2016, the CPA, this was before MAiD for mental illness was even on the horizon. 75% objected. Only 500 of 5,000 psychiatrists responded. 2020 in Quebec, only 263 of 1,300 psychiatrists. So again, very small samples, but I think the samples are pretty clear. We've got some pretty substantial splits. 42% said we need at least 10 years of treatment before we can even consider that further treatment might not help. These are psychiatrists. I will argue there's a whole range of skill and experience in psychiatrists. If I were a younger, idealistic psychiatrist wanting to fight for liberty and justice, I'd be saying, yeah, I'm going to respect your autonomy, you choose. As an old guy who's been around the block a long time, and my sampling, I've probably treated about 10,000 people in my career. It's a much smaller number than most psychiatrists because I see smaller numbers because I only specialize in the severe illness. This view that you can't treat is a reflection of skill set in part. I want to be clear on that. If I have a hard to treat illness, I want expertise. Our OMA Ontario Association, again, only 269 psychiatrists, but look at the numbers. I'm going to highlight the third one there, the second one. 91% do not support it without standard treatments tried. That's not Canada. There will be no requirement that standard treatments be tried. Let me put this in perspective. When the law comes into effect, I can go into my family doctor's office, be diagnosed with depression, and get MAiD, whether it'll be the next day or they'll say 2 months or 3 months. It certainly won't be years, because that will be argued to be discriminatory, as they did with disabilities and terminal illness, right? The push has been to shorten the interval. So I have to wait years for treatment, a year commonly for a psychiatrist consult in many areas of Ontario. And that's what's going to come. So what does this mean for Canada? Our values are shifting. There is a dignity fallacy. And it's frustrating to me that happens. Faith-based values and conscience rights. As an ethicist, I find it fascinating that MAiD advocates are quite comfortable criticizing a faith-based position. Make no mistake, all the all the religions and major religions in Canada have signed letters to Parliament. They're all on the same page. This is wrong. This is supporting suicide. But we're talking a couple of thousands of years of thoughtful ethical reflection. So I find it remarkable that bigotry is so openly expressed towards religious positions on this, rather than looking at the reasoning behind the position. Because the ethical reasoning, the logic of it is sound. And this look at the argument with or without God in the picture, and you've got sound argumentation about our duties to each other as human beings. Autonomy, there's a fascinating pendulum shift. Me, not us. False mercy, I've talked about white coat. I've talked about all of these things. Ableism, the disability associations are screaming that this is ableist in the worst way. And the one piece I'll add there, we have an ethicist in Ontario who's argued that medical students should not get in, you should not be accepted to medical school unless you are willing to do MAiD. And that is flat out discrimination against people. And if you look at the Canadian census data, 70% of Canadians, 70% report holding faith-based values. I'm not talking about who goes to church, but there's something they believe that's important. And we're talking about overt discrimination as though that's acceptable from an ethicist, which disturbs me. Treatment capacity, I'm not going to spend much time on this. It's become a bit of a red herring here, with MAiD advocates saying, you know, people who are against MAiD for mental illness are claiming all people with mental illness are incapable when they're not. No, we're not saying that. We're not saying they're incapable. We're saying capacity should be assessed. If someone's quite psychotic, if they're clearly despairing because of profound depression, if their judgment is overtly, clearly impaired, get them better and see what decision they want to make when they're feeling better. But it's become complicated. It's been made messy. We have made assessor bias. If this is what you're choosing to do as a profession, if you're a doctor who wants to kill people for a living, you're going to have a particular bias when you're assessing people. And in the most recent article, came out a couple of weeks ago in a policy journal, said there's something inconsistent about saying I should be refused MAiD for schizophrenia, but I could be approved for cancer. That's what logicians call a categorical fallacy. There are different states, different conditions, different criteria, different abilities to understand what's going on. And you're refusing on the basis of schizophrenia because it's treatable. You're not refusing on the basis of cancer because it's terminal. And that should be clear. Emotions matter. I just want to throw this in. People say, and MAiD advocates are saying over and over, we already do capacity assessments for people with terminal illness, so this is just the same. I'm sorry, it's not just the same, because your brain is affected, and with it, potentially judgment, cognition. No physical diseases have suicidality as a diagnostic criterion. And capacity is complicated. There's descriptive capacity. What should a rational, reasonable person look like? Demonstrated capacity. What is this person doing? Normative capacity. What does the law say? The law says in Ontario, you have to understand and appreciate. Your brain has to be working. You have to know what this means for you, which means people with anorexia, the highest death rate of all psychiatric disorders, that they will say the right things, their brains are working, and still they don't eat and they die. That is not demonstrated capacity, okay? Anyway, it's complicated. So as Louis Charlat, a brilliant philosopher from Western, said, I don't want to be treated like Mr. Spock on my deathbed. I'm a complicated human being with a life story and values that I want respected and understood. And I want you to know why I'm suffering. And if you can do something to help it, help it. But where we have a culture now that offers MAiD quickly, there's an emergency room I was in, they had MAiD pamphlets in the emergency room, thinking, wow, what would drive that? And we have all kinds of press stories now about people being offered MAiD, right? When they're not terminal, when they can be treated. And those stories are going to be hitting the press more and more. I'm going to be wrapping up here. These are the reasons we're seeking death. Sephora is going to be talking about this. These are the things we know that people say, and look at them. These are things we can fix. Okay. We have a mental health system. We know we can save billions with treatment. So people say we don't have money. It's not about not having money. It's about choosing not to spend it. The Mental Health Commission has said for decades that we can save a fortune. And what have we got in Ontario? We've got, or Canada rather, 90,000 doctors and nurse practitioners, all the behind closed doors exchanges. Tell me there isn't going to be inducement or pressure. And we know in the one country, Belgium, one psychiatrist was responsible for all mental health care deaths. People will doctor shop till dead in Canada. There are going to be people who are activists and who are ideologically convinced that people should be allowed to die whenever they want, even if they can get better. Okay. MAiD is suicide. I've talked about this. I will add one thing here. We have a study from Switzerland. These are not the beautiful deaths of terminal illness that the press presents here. 40% of people involved with the death of a family member with a mental illness are diagnosed subsequently with depression or PTSD. It is an agony to watch someone die who could live. Safeguards, this is a talk for another day. The stuff that comes out tomorrow, it will be full of problems. There's no other way around it from an ethical analysis perspective. And that panel report comes out tomorrow. So, validating assisted suicide removes barriers, makes it the norm, perversely makes caution appear, I forget what I wrote there, not good. And money, make no mistake, this is a money issue for governments. They are saying so behind closed doors. It is a fact. It's cheaper to kill people than care for them. What does the future hold? It's not going to be good, given how widely this door has been opened. And I'll end there. Thank you very much.